So ladies and gentlemen, will you please welcome to the stage Dr. Lamar Hasbrook.
Good evening. So let me add my personal welcome to everyone as well. We have an amazing lineup of educational and social events planned for you this week. I'd like to thank you for making this journey to join us for NACCHO Annual 2016 in Phoenix in the summer with an average heat index of 115. So thank you, that's dedication. So for today's panel, we have rounded up 3 extraordinary speakers and thought leaders to share their perspectives on collaborative pathways for advancing the future of local public health. Our speakers today are Karen DeSalvo, Leandris Liburd, and John Auerbach. Please welcome me as I join we have our panel come up and join us. Thank you. Okay, so I'm going to introduce each of our speakers in turn, and they'll come to the podium and share their perspectives. So the first speaker I'm going to introduce is Dr. Karen DeSalvo. She is the Acting Assistant Secretary for Health in the U.S. Department of Health and Human Services. She's a physician who has focused her career toward improving access to affordable, high-quality care for all people, especially vulnerable populations, and promoting overall health. She has done this through direct patient care, medical education, policy and administrative roles, research, and public service. The Office of the Assistant Secretary for Health oversees 12 core public health offices, including the Office of the Surgeon General and the U.S. Public Health Service Commission Corps, as well as 10 regional health offices across the nation and 10 presidential and secretarial advisory committees. The office is charged with leadership in developing policy recommendations as they pertain to the public health issues that cut across HHS agencies and operating divisions. Dr. DeSalvo also remains in her role as the National Coordinator for Health Information Technology, where she continues to set high-level policy and strategic direction of the office, including efforts related to interoperability. The Office of the National Coordinator for Health Information Technology is at the forefront of the nation's health IT efforts to adopt and meaningfully use health information technology and collectively achieve health information technology interoperability as a foundational element of better health care for everyone in America. Please welcome Dr. Karen DeSalvo to the podium.
Well, thank you, Lamar, and thank you to NACCHO for letting me be a part of this extraordinary panel with colleagues that I very much admire. I'm going to make some remarks and then have an opportunity. I'm looking forward to some of the Q&A. I did just want to say how great it is to be here. I was on the board of NACCHO for a little bit of time, a minute, as we say. And then when I took my job in Washington, I had to step down, and then I was recused from NACCHO for 2 years while I was in Washington, and it was actually literally painful. So it's wonderful to be here with people I consider to be my kindred spirits. You guys do such important and amazing work every day on the front lines, and I just want you all to know that you're my heroes, and we're fighting for you in Washington and everywhere we go, and I think that your time has come. It is public health time in this country, and I'm going to tell you a bit about why and what we've been learning from the field. I certainly don't want to come here today and tell you what I think our major public health challenges are as a country and how to solve it, because as I know, you all are addressing those and solving them on the front lines. What I want to share with you is about a conversation we've been having across the country, something that we're calling Public Health 3.0. It is a version of public health that is being pioneered on the front lines and is taking advantage of tumultuous changes that are happening in this country around health in general. We have had amazing progress in advancing access to quality, affordable care in this country. Just in the past 7 years, because of the passage of the Affordable Care Act, we've had the opportunity to see that 20 million Americans now are newly covered in some program. We've seen that there have been expansion of benefits to include mental health as an example, preventive services, and we're seeing that we still have work to do, but we're making progress every day. Our work in the marketplace is not over, and if y'all are involved in that, I'm here to tell you open enrollment 4 is going to start in the blink of an eye. So take a deep breath, because we're going to be coming after y'all with, with the need to help reach everybody so they have the opportunity at coverage. But the same work is going on around Medicaid expansion, because those who are the lowest income in our communities are the ones that we need to reach the most. We've been making a lot of progress as a country in seeing that we can improve the care that is delivered, the quality of care, reducing harm, seeing that it is increasingly person and community-centered. I was at a local hospital this morning doing a site visit, one of the Indian Health Service sites, and saw some extraordinary work in patient-centered medical home and population health, but really just very meeting people where they are. And that's the direction we're pushing the healthcare system. We've been doing that through policy levers like changing the way we pay from Medicare to move towards value-based payment, setting goals such as 50% of payments will be in alternative payment models by 2018, and working backwards, we're making progress to see that the payment structure doesn't get in the way of really great quality care. We have been doing work with folks like you all and with the private sector and healthcare delivery system to reduce harm, estimating 87,000 lives saved and some $20 billion of funds. That savings, we hope, is an opportunity for all of us going forward to begin to make reinvestments in areas that really impact health. You all are also experiencing changes, not just what's coming from the Affordable Care Act and how that's changing the delivery of care on the front lines, but you're also experiencing, I think, a change in technology and data. It's causing new opportunities for communication with your communities. It's causing new ways for us to aggregate and use data, data that is perhaps uncomfortable and different and not as perfectly curated as it has been in the past. And I think finally, I just want to acknowledge that the underfunding of public health, or even where there has been flat funding, has been a major challenge. The Great Recession had a dramatic impact on local public health in particular, and that caused many of you to look to how you could do the same with less, and at some point you're making decisions that you just have to do less with less, and that is causing you to really reevaluate your role and responsibility in every community. So it's within that context, though, that many are finding, I think, a lot of really exciting opportunities to move forward and do exactly what is the definition of public health. This is a modified version of the 1988 Institute of Medicine definition, one in which we've added a couple of words that seem relevant also for today, that public health is the collective actions of a society to ensure the conditions in which everyone can be healthy. Collective being an operative word, one I'm a firm believer in, that it's going to take not only all of us in the public health infrastructure, but with our partners across all sectors to see that we can drive a society towards conditions that bring equity, that create health for everyone, and really eliminate the disparities that have so plagued us. We have great work to do, but I can think of no better champion for this than public health. The work that we are seeing that on the front lines about this collective action approach where public health is at the table, often leading at the table, builds upon the great success of public health. And I certainly want you all to know that we completely believe in and understand that there's a foundational component to public health that has led us to expand life expectancy, to improve the quality of life for people not only in this country but across the globe. That work cannot be stopped. These are the basics, as you might imagine, though honestly we've forgotten some of them in some communities in this country. Public health's involvement in sanitation, in water systems. These emerged in a time when the epidemiology pointed to communicable disease, and it was the focus of public health at that time. But as the epidemiology evolved and as culture evolved, so did the work of public health. And in the mid-20th century, adopted additional work addressing the non-communicable diseases, cardiovascular disease as an example, but also emerging threats to health like HIV/AIDS, and new responsibilities in areas like preparedness. This was also a time when public health became more defined as a practice, and the emergence of efforts like accreditation. And by the way, congratulations, Bob, on your accreditation. It's a really solid advancement. But this is the professionalization of the work that we do every day. And maybe we'll advance. Which kind of brings us to today. And we are not, let me be clear, this is not a new invention. I'm not attempting to invent the wheel here. What we are working to do with this Public Health 3.0 national conversation is describe something that we are seeing not only in the literature, but happening every day on the front lines, and try to weave together what we think are the important ingredients or components and understand how we federally can enable or support or get out of the way, and what are the other opportunities for other sectors like business, like elected leaders, like healthcare, like civic society to be engaged in this movement to see that collectively we're advancing the health of everyone. In the paper that we wrote, John Auerbach being a co-author, we talked about this as a significant upgrade in public health practice to a modern version that looks at cross-sectoral approaches that tackle challenges using environmental or policy or systems level approaches, and really think about all the determinants of health, including the social determinants where we live, learn, work, and play, issues like community violence and racism. This is a time when public health steps outside of the health department and really becomes the chief health strategist on the ground, using John's language. This all is happening in the context of what you all know about from your CHA-CHIPs and that you've done using your MAP process of the broader public health system. I always tell folks I have the public health agency. This is also a CDC slide, and the public health system is like right smack in the middle of the agency. I guess that's our centric view of the universe, but that's where I believe we ought to be. Because if you're really thinking about advancing the health of communities, it's not something that we do in public health just because it's interesting or because it seems to be the du jour thing or because the payment system coming out of Medicare is pushing us in that direction. It's your responsibility. It is what you get up in the morning and do all day. It's what you think about all night as you're on call every day. You have the responsibility and accountability to everyone in your community to see that they remain healthy or can become healthy, but are such a critical part of this broader system. I think certainly what we're seeing across the country is that public health agencies are increasingly leveraging the rest of the broader public health system to advance health, especially when they're thinking about the social determinants. We have been thinking about this framework of Public Health 3.0 as there being 5 critical path issues. These are probably the core ingredients mixed together in a variety of recipes to work on the front lines. And it's a recurring theme, not only in what we read and hear, but what we're seeing on the front lines. It's about leadership and workforce. In other words, types of leadership that are more meta leadership, more strategic, thinking outside of the traditional role of running the silo, but really being able to address the social determinants. They're taking advantage of big data, new types of data. They're using the opportunities around new analytics, and they're thinking about metrics that are, in some cases, community level metrics, whether that's about the built environment or about public safety, just to give a couple of examples. They're paying attention to the essential infrastructure. Many of these departments are accredited or are on their way to being, because they're recognizing that they have an accountability for the fundamentals, but they're also thinking about a structure that allows them to be more nimble, as Claude said, and more flexible going forward, which brings you to funding, which is not always about more funding, but also about funding being less stiff, seeing that we're not funding a particular disease or content area, but providing a platform of funding that allows you to meet communities where they are and surge to new public health challenges. And finally, strategic partnerships. And frankly, doing those takes money, it takes time, it takes infrastructure. They don't just happen on the fly. These are strategic partnerships that sometimes might be considered unusual in an older frame of public health, though I am often reminded, and I do know, that public health's origin, some of the best work that we did in, for example, reducing the scourge of tuberculosis was when we worked on housing policy in this country. So we're very familiar with working with strategic partners. This is simply, we think in many ways, a reminder of that. We have had 5 conversations structured across the country. We were in Allegheny County in the North Bay area of California. We were in Kansas City, Nashville, Tennessee, and most recently we were in Spokane, Washington. The local public health leaders there, those that came from the region, participated in a day-long conversation that not only provided a spotlight on great work that's happening to help us put some shape and frame on what Public Health 3.0 is, but they also did workshops in the afternoon where we were pulling together recommendations about what would allow public health to really move forward to this version that gets beyond the work that we're doing today and into a space where we can really more nimbly and more sustainably address the social determinants of health on top of the other work that we're already doing. We've got some wonderful conversations and feedback already for recommendations that point to us federally, but also point to other sectors like academia and business and local electeds. We're going to be putting those out in the fall. We've set ourselves a date, October 18th, where we'll be webcasting the annual meeting and look forward to some feedback, not only from what's happening at the national meeting that we pushed out, but we're going to do 10 regional meetings in follow-up to see that we can get some on-the-ground recommendations about what will work. And we look forward to working with NACCHO, ASTO, and others to see how we can carry forward this work. I think that where I wanted to end is just to say that this is a shaping of a conversation nationally about where public health is going. These pioneering health departments that are showing us that they are creating the conditions in which everyone can be healthy. They're doing it collectively with others. They are the underpinning to what Raj Chetty and others saw in their data published in JAMA. Data that on the negative side showed us that life expectancy is declining for many in our country, for some folks who are particularly in the lowest income levels, but for certain communities overall like Tampa. But there are other communities that have sorted out a way to work together, and they're doing that often by working collectively, often by tackling these 5 key areas and really thinking collaboratively about how they're going to share money, how they're going to share resources, how they're going to put people first, put community first. These are incredibly exciting models where I've seen business in the Nashville area, for example. I was confused by the Chamber of Commerce leader. I thought he was the local public health official, the way he was talking to me. He was so well indoctrinated in the language of public health. And when I have a conversation like that, I have so much hope and excitement that if communities like that, if sectors like business, amongst many others, can understand the language of public health, understand the importance of public health as a core infrastructure in our country, that we're going to have an opportunity to reverse some of those trends that we're seeing in the data, to find a way that the communities where disparities are narrowing, to create a culture of health equity in every community in this country. Public health is the natural leader, the natural chief health strategist, John, to make this happen. And I'm going to say finally that I think this really must happen at the local level. This is what you all are figuring out every day, and I thank you so much for those of you who have already participated in the conversation and look forward to more dialogue. Thank you.
Thank you, Dr. DeSalvo. So the next speaker I'm going to introduce is Dr. Leandris Liburd. She is the Director of the Office of Minority Health and Health Equity at CDC. In this role, she oversees the work of CDC's Offices of Minority Health and Health Equity and Women's Health and Diversity and Inclusion Management. In addition, she provides agency leadership, direction, and accountability for CDC's policies and programs to ensure that they are effective in improving women's and minority health. She also serves as the agency's principal advisor on health equity issues with the Department of Health and Human Services, other federal agencies, national associations, academic institutions, and the public. Dr. Liburd is a respected public health leader who has, over the course of her career, championed community health promotion, chronic disease prevention, community health engagement, eliminating health disparities, and addressing the social determinants of health. She has worked in the public health at the local, the state, and the federal levels, and has held a variety of leadership positions at CDC since joining the agency in 1987. Dr. Liburd has published extensively on community-based public health approaches to chronic disease prevention and control, the influence of culture and gender on health beliefs and behaviors, and racial and ethnic disparities. In 2010, she published her first edited volume, Diabetes and Health Disparities, Community-Based Approaches for Racial and Ethnic Populations, which serves as a key resource for those interested in socio-ecological approaches to reducing diabetes disparities. Please join me in welcome to the podium, Dr. Liburd.
Thank you, Dr. Hasbrook, and good afternoon, everyone. I also want to give special thanks to the 2016 conference planners for inviting my participation into this very, very important meeting. This is a special opportunity for the Office of Minority Health and Health Equity at CDC to be able to share with you the evolution of the work we've been undertaking to actually cultivate the science and practice of health equity across CDC and with our colleagues in state, local, tribal, and territorial departments of public health. I also want to take the opportunity to thank Dr. DeSalvo for her leadership at the level of the Assistant Secretary for Health in pushing forward the next generation of public health that puts the social context wherein health behaviors are shaped and health outcomes are mitigated at the forefront of our work to ensure that all persons are able to attain the best health possible. So I wanted to just give you a brief overview of the work that we're doing and the impetus for that. In April of 2014, the Health Disparities Subcommittee, which is a subcommittee of the Advisory Committee to the CDC Director, submitted 6 recommendations to Dr. Frieden of actions that they feel strongly we should pursue to better integrate health equity into our public health programs. And today, I just want to describe progress to date on achieving the first one, which is to develop a CDC framework for action to achieve health equity. The subcommittee was very intentional in its language for an action framework to move us from the conceptual and aspirational to practices and operational guidance. So in identifying operating principles for health equity, it has been a long-term and inclusive and iterative process that began with an internal assessment of how the national centers, institutes, and offices at CDC were currently addressing and understanding health equity. We also reviewed the literature and identified programs implemented in communities across the country that were focused on health equity, and then we recently, just in April, convened state, local, tribal, and territorial offices of minority health and Centers for Health Equity to get their feedback on the proposed operating principles and practices. And I've been able to run into some of my colleagues today who were there in April, and it's very good to see you. We are working with ASTO to synthesize their feedback, and then we will make revisions to our principles that will enhance both the feasibility and the acceptability of the approach. When I was interviewed by Dr. Frieden for my current position, he asked me this question. He said, what is the contribution of public health to the social determinants of health? And so as we began the thinking process for this framework, I thought that it was important to orient our model with core functions of public health in mind. So as you can see, we have to have an infrastructure, and this is our infrastructure within departments of public health that supports health equity, and then that infrastructure should have the expertise and the resources to collect, analyze, and interpret data on health disparities, on health inequities, and social determinants of health. Our program should include design elements that promote health equity and policies with the explicit goal of improving health for all people while reducing health inequities. And I want to just say I'm not going to take time to define the different terms, but I will say that health inequities are those things that are systematic, they're patterned, we can anticipate it, they're unfair, and they're unavoidable. So data, as we all know, is foundational to public health programs and policies, and understanding the drivers of health inequity invite different and more complex indicators and methods. And so I just wanted to highlight some of the principles that we've identified in terms of measurement. We have to consider issues of power and power dynamics within communities. And we need to be able to measure that change over time. We have to compare multiple social statuses, and sometimes we talk about that in terms of intersectionality and the different identities that people have to negotiate in different social spaces every single day. We have to assess social and structural determinants of health, and then specify our methodological choices. And then we have to consider our stakeholders' communication needs when selecting analytic methods. We find, for example, that qualitative methods like storytelling and focus groups and other kinds of qualitative strategies are even more appealing and can mobilize communities in a more powerful way than the conventional, kind of more arguably rigorous quantitative methods that we tend to prefer, certainly at CDC. In terms of essential program elements, we have to consider the socio-demographic characteristics of our population. And again, this is an opportunity for us to understand more the multiple identities that people take on. We have to understand the evidence base for health disparities and health inequities. And what our office has been able to do in 2014 and then again this year in 2016 was to sponsor an MMWR supplement on CDC-sponsored programs that are effectively reducing health disparities. We understand that that is different from strategies that effectively reduce health inequities, but we see that as part of the future, our needing to do that, kind of based on the work that you all are doing, being able to identify that evidence base. We have to leverage multi-sectoral collaboration, as Dr. DeSalvo said, mobilize community engagement. We need to use clustered interventions. We learned a long time ago that singularly focused interventions are not going to tackle the complex public health issues that we're now confronted with. I say again, engaging with communities. I don't know how many times that we have to reiterate that. Certainly at CDC, the necessity of engaging community voices and perspective. And we also have to plan and evaluate our programs rigorously. There are a number of national policy initiatives in place and tools that are available to facilitate the development of policies such that we can see health in all policies. Dr. DeSalvo mentioned the Affordable Care Act. I don't need to say more about that, but there's also the National Partnership for Action to End Health Disparities and the National Stakeholder Strategy for Achieving Health Equity, which are national initiatives that come out of the Office of Minority Health at the department. There is the Healthy People 2020 Social Determinants of Health topic area, which reflects a topic area that is the first time in the history of Healthy People where they had an exclusive focus on social determinants. And if you go to the website and go to the social determinants of health topic area, there's also a resource portal with examples of local and state initiatives that are successfully pursuing social determinants and health equity. So we also, as I mentioned, we had the opportunity to develop a health in all policies framework and to use health equity impact assessments as a tool to get to health in all policies. So the public health infrastructure should I think at a minimum, if we are going to be able to pursue health equity, is we have to develop and maintain a culturally and linguistically competent workforce. We have to develop appropriate data systems, assure accountability at high levels of the organization, and also that we have effective and consistent leadership at high levels of the organization. Leadership matters if we're going to pursue health equity, and so I can't, again, overstate the necessity of having support at the highest levels of your organization to pursue this work. So we get asked often why we don't just use the World Health Organization framework. And there are a lot of frameworks out there, and they're all good. And I just wanted to just be on the record as saying we are big proponents of this framework. But we also recognize that departments of public health are at different stages of readiness to really be able to apply this model to whatever their public health issue is. And so we believe that by taking this kind of a component approach, if you will, we give departments of public health as well as our CIOs at CDC an opportunity to build the experience and the knowledge and the expertise that's needed kind of en route to applying this, the World Health Organization framework. So everything that I've talked about today is elaborated in this special issue of the Journal of Public Health Management and Practice that was released in January of this year. I encourage you to get a copy, to take a look at it, to provide us feedback, and we hope that this special issue adds to the dialogues that are going on around the country in terms of addressing health equity and Public Health 3.0. We also hope that it'll be helpful to our colleagues in the academy as they are training the next generation of public health workers, and also that it be used for continuing education. And so with that, I'd like to thank you for your time and your attention, and let's continue to work together to achieve health equity.
Okay, so I have one more all-star to introduce, and that is John Auerbach. He is the Associate Director for Policy at the CDC and the Acting Director of the Office for State, Tribal, Local, and Territorial Support, or OSTILTS. He oversees the Office of the Associate Director for Policy, which focuses on the promotion of public health and prevention as components of healthcare and payment reform and health systems transformation. Previously, he was a distinguished professor of practice in health sciences and director of the Institute on Urban Health Research and Practice at Northeastern University from 2012 to 2014. John was the Commissioner of Public Health for the Commonwealth of Massachusetts from 2007 to 2012. And under his leadership there, the department developed an innovative program, a number of innovative programs to address racial and ethnic disparities to promote wellness, including Mass in Motion campaign, to combat chronic disease as well, and to support the successful implementation of the state's healthcare reform initiative. And prior to that, John was the executive director of the Boston Public Health Commission. He did that for 9 years, during which health equity and emergency preparedness and tobacco prevention became major priorities. In addition to Boston's public health programs, he oversaw the emergency medical, homeless, and substance abuse services. Please welcome our last panelist, Mr. John Auerbach, my friend.
Well, good afternoon, everyone. It is a pleasure to be here. It's a pleasure to share the stage with the doctors on my left. And I have to say, it's a particular pleasure to be at the conference this year when Claude Jacob is the president of NACCHO. Claude and I work together in Massachusetts as local health officers, and your leadership is just outstanding, has been at the local level and at the national level. It's great to have you in that role. I'm going to share with you some of the work that CDC is doing on the issues that we're discussing. I want to start, though, maybe just by saying I was a member of NACCHO for 9 years when I was a local health officer, and 4 of those years I was the chairperson of the annual planning committee for the conference. So I want to say I really know what went into the people who organized this event. So could we give a round of applause to all the people who organized? To have a conference this large and this well organized is really a tribute to you, Dr. Hasbrook, and your team. This is a slide of the 3 strategic directions at the Center for Disease Control. The top 2 strategic directions might not be surprising to you. Global health and focusing on the leading causes of death, injury, and premature death seem pretty obvious. But often people are surprised by that one at the bottom, the strengthening the linkage between public health and healthcare collaboration. That's made it into the top 3 strategic directions of CDC. And the reason that it has is because we do live in this extraordinary time period now. We are in a period with the passage of the Affordable Care Act where we have close to 20 million more people now that have health insurance that didn't have health insurance before. And we've also seen under Dr. DeSalvo and the Secretary's leadership a transformation of the way that we pay for health care. So we're moving away from fee-for-service and we're moving more towards value-based contracting for care. This creates lots of new opportunities for us in public health and for you at the local level in particular. It's opportunities, but it's also challenges. Thinking about the implications of those 20 million more people with insurance and what that means in terms of the safety net and the services we've historically provided in public health, thinking about those new insurance opportunities and whether we can squeeze in some more prevention and population health into coverage. It's exciting, but public health folks need to be at the table, and when we're at the table, we really need to be able to have concrete and specific proposals and demonstrable value in the discussions that are taking place in our communities. To think about that, CDC developed this framework, the 3 buckets of prevention. And the idea behind that is that we're going to be sitting at tables where people are talking about prevention and population health, and they're going to mean different things as they use the same words. And we don't want to get into a battle over whether one or another definition or approach is the right approach. We in public health need to be able to accept and value the various approaches to population health and prevention and be ready to offer concrete, valuable recommendations for how we can move ahead. The 3 buckets approach is a way to think about that. First bucket being what can be done that promotes prevention and public health in traditional clinical services that are paid for by fee-for-service historically, but can take place in 15 minutes. This is the immunization, screening for disease, counseling someone on giving up smoking. We're not doing a great job in terms of accomplishing all those with clinical care, and we need to think about how we can do better. Public health has a role there. Second bucket is the opportunity that's created by that transformation in the way that we're paying for health care, the possibility that we can pay for some of the approaches that public health has proven work and that public health is paid for. And those include community initiatives that get care for a patient or the patient's family outside of the clinical setting into the community. They include things like the diabetes prevention program, a lifestyle multi-session program that can take place, the YMCA or other community settings led by a non-clinician. They include community health worker going into the home of a family that has a child with moderate to severe asthma and working to reduce the triggers in the home and working to educate the family and help sometimes with just material changes in the home. We want to make sure that insurance is increasingly paying for that as we move to value-based contracting, and that takes concrete and specific proposals for how to go about doing that. We want that for a couple of reasons. It's the best thing for people's health, but it also will free up money from public health, and it will allow us to scale up some of the programs public health has shown are effective. And then the third bucket is the moves away from the patient-oriented approach and thinks about the changes that are necessary at the neighborhood, the city, the county, or the state level with laws, regulations, and policies to make sure that people are in communities and environments where healthy behaviors become the norm and are encouraged by the environment. And those are sort of the traditional things public health is familiar with. The point here is we need all three buckets, and we need public health to be nimble in terms of operating in all three of those buckets, to be ready to be able to show public health knows how to promote health in creative ways that these new opportunities create. At CDC, we're developing tools that may be helpful in terms of taking on that challenge. One of those is the 618 program. The idea behind this was to be ready for the interventions in Bucket 1 and Bucket 2, patient-centered interventions, with concrete and specific proposals that address 6 different areas where there's high burden, high cost health concerns, the 6 that you see listed here. We went through hundreds of different approaches to how to address those 6 concerns, but we looked for those that we could have solid evidence that within 5 years or less, if insurance was paying for this, health would improve and the cost would be controlled. You'd have no additional cost. In fact, you'd have reduced cost. And we found that there were 18. Some of these 18 fall into Bucket 1. They include things like eliminating cost sharing for the prescribing of some chronic medications for blood pressure and the like. And they include interventions in Bucket 2 that such things as the ones I'd mentioned, diabetes prevention program and community health workers going into the home. We think we put this onto our website, 18 evidence-based packages. They've been looked at and approved and rewritten by actuaries and the insurance companies, so it's in their language. It makes the case for a return on investment for the adoption of these 18. We're working now with the Medicaid programs across the country, 9 of whom are piloting 618. And we're also working with commercial payers. We just convened the 7 largest commercial payers in the country last week to go over the 618 with them, and we're working in partnership with them as well. An example of the kind of success you get with this approach was the Secretary of Health and Human Services and Dr. DeSalvo's announcement to cover the diabetes prevention program with Medicare funding once the process of rule setting is determined. And that will have an enormous impact on the health of elders within this country. Hundreds of thousands of them will take advantage of this as a result of that kind of coverage. These are just examples of the kind of summaries that are available on that website, which, by the way, is cdc.gov/ and then the word 618. But we also wanted to work in that bucket 3, the community level, the city level. And to do that, we applied something of the same approach. We looked at the evidence-based interventions that had been attempted at the city, state, county level, and we looked at which ones of those had a solid evidence base that in 5 years or less, health improved. Not just behaviors improved, not simply that something was done which seemed to make sense that this would probably lead to health, but we looked for solid evidence in 5 years health improved as a result of these interventions. That was criteria one. The second criteria was it had to have a positive impact on cost, bending the cost curve over some period of time, if not within the 5 years in all cases, but over some period of time. And we found that there were 14 of those. And those are ones that operate at that lower end of the public health pyramid that I think many of you are familiar with that are shown here. The end of the pyramid that focuses on changing the conditions in the community, and at the bottom of the pyramid that focuses on the social determinants of health. What are some examples of these 14? Well, they include activities that are within our experience as public health professionals, like wearing helmets for when you're riding a motorcycle, like fluoridation, like pricing strategies for tobacco and for alcohol, and needle availability. But they also include many other approaches that operate outside of the traditional public health arena, and they include such things as retrofitting vehicles so that they're not as polluting. They include housing vouchers to improve housing that is subpar. They include public transportation. They include earned income tax credits. Now, we didn't do the research on this. This was no original research. This was CDC simply looking at the literature and saying what met that 5-year criteria with solid, compelling evidence. And we found these. So with this initiative, which we refer to as High Five, which stands for high impact, health impact in 5 years or less, you could go to your elected official and say, you know, by the next time you're running for office, there are some things we can guarantee you from, if you implemented these from a policy perspective, they would result in a positive health outcome. This isn't to say we shouldn't work for things that have a generational change. This isn't to say we shouldn't work for things that really do cost a fair amount of money, but we know they work in terms of improving the health and welfare of the population. But it does mean that when we're at a table and we need to have some solid evidence-based approaches we can pull out that meet the criteria of these work in a short amount of time, we're ready for those. Here's an example of one of those again. Early childhood education was one of the 14. By the way, we also have available on a website information that may be helpful for you in terms of looking at the social determinants of health and working to identify resources in your hospitals at community benefits as well. We developed these together in the policy office and the office that Dr. Liburd oversees, and they may prove helpful for you just in terms of gathering best practices, gathering evidence, putting together materials you may find helpful. This is just to bring it down from the 3,000-foot level to the concrete and specific level of the folks that we're working with as our neighbors and the people in our communities. This is Miss Edwards. She's one of the 20 million people that didn't have insurance, that now has insurance. She couldn't address the health issues that she needed to be addressed before the ACA, such things as high blood pressure and asthma. She now has a doctor, primary care, gets the medication she needs, and she is definitely healthier. But is that enough? Is that enough? It's critically important, it's absolutely necessary, but it's not enough for Mrs. Edwards because of these characteristics. She doesn't make a lot of money. She lives in a neighborhood where buying healthy food's not easy or affordable. She lives in a neighborhood that's not the safest neighborhood to exercise outside in, and she lives in subpar housing. So she can get a number of her health issues addressed in a high-quality primary care setting, but unless we're also working on these issues, we're not going to optimize her health. We need to work in all three buckets for Ms. Edwards and others. And so this is just an example of the argument we might make with our partners in the payers, the providers, the hospitals. Let's work in one of the buckets. Let's make a contribution in terms of what takes place in a clinical setting, what takes place to address your health issues in your home, in your neighborhood, and how can we change the conditions of your life. By working on the issues in all three buckets in an aligned way across the different sectors, we're able to make an impact on Miss Edwards that will optimize her health as well as optimizing the health of the other people in her family, her community, her city or her county, the state and the country. So thank you very much for the opportunity to share these examples, and we do look forward to continuing to work with you at the local level and making an enormous difference on the health of the people of the country. Thanks.
Okay, so now is the fun part. I'm looking at our timer here. We have about 15 minutes or so to interact with you all. We have 2 mics. We have one here and one there. We also have this cool thing called a mic box or something. So if you're feeling kind of lazy, don't want to get up, we can toss you this. And this has a microphone in it, and you can ask your question directly in here, and we can get it that way as well. So I'm going to give it to Oscar, and he'll get it around to you guys. So as you guys are lining up, I'm just going to pitch one question to the panelists. One of the panelists, Dr. DeSalvo, coming your way, as you guys get lined up. So we always ask for money. We always ask for resources. But I'm going to ask a different question. It's not really about more money. It's really about the flexibility and how to use money. Because sometimes, you know, the key to success is using what you got smarter. So my question to you is, what's happening on the federal level to allow us as practitioners at the local level and also at the state level to really be more flexible with the funding we get, to braid it together, to do more with that, and to actually bring others under the tent to help us in doing that?
Well, let me start first at the local level, and then I'll talk about some federal efforts. The local level, one of the strategies that we've been seeing, for example, in Washington State, is that the local health departments are recognizing that, say they need to do food handler training, they may not need to host that class for the 5 people that would come. They could share that service with their partners across county lines. So I'm seeing a lot more efforts like that where local health departments know they have a statutory or other obligation, but they're thinking through the fact that they don't have to actually do every one, and they're finding ways to use technology or use their partners to accomplish that so that they can then turn their attention to other opportunities around funding. I think in a similar way, we're seeing strategies at the local level where the health departments are part of either you could call it a platform organization or an umbrella organization, depending on the language you wanted to use. It's a collective impact model where they've come together, often in a very structured format. So like Rex's team in Kansas City has this. They have something in Nashville called Nashville Health. Each of the cities that we went to or counties has this. And they're actually sharing funding. So even places, Erie, Pennsylvania is doing this. They've set clear goals. They're pooling their money, and in order to access those funds, whether you're public health or an NGO, as a global term, you need to be tackling those in concert, and that's causing them to then not all do an after-school program that's distinct from each other, as an example, but work together in concert. I think what we have to learn federally is a couple of things. One is, how do we better align our expectations around grant reporting, around grant eligibility? I think we also have to learn how we do that, not just across HHS, but across all of the federal partners. I know, for example, if you want to do work in violence reduction and you're receiving funds from SAMHSA and from DOJ, it's quite complicated, and there have been some attempts that we've got some lessons learned around. But I would say that though the will is there and we're looking for ways that we can simplify the grants, we have quite a lot of work to do to make sure that we make it much more straightforward on the ground.
Thank you. Mm-hmm. So let's get to the questions. I'm going to start here because there's 3 on this side, and I'll get to you next. Please.
Thanks. C. Davis from Virginia. It's really exciting to have this team of presenters because the experience clinically and feet on the ground, shoe leather public health, is really reassuring to us out here. So something that's been on my mind a long time, and especially on my mind when we talk about no copay for key conditions. Basically, pharma is in a position where there's the bottomless opportunity to charge anything they want for medications, and we're seeing the effects of that. Companies have stopped making each other's drugs and generics, and so the price is being set under the free market system pretty freely. Canada and other countries collectively bargain as governments. I understand there are impediments to our government doing that. What would it take for Medicaid, Medicare, and TRICARE to be able to join under the government umbrella to bring pressure to bear for reasonable prices for these drugs so that we will not contribute to our skyrocketing deficit by requiring no copay?
Great. So, Dr. DeSalvo, we'll go to John.
So let me just start by acknowledging and agreeing with you that we think that's an incredibly important priority for many reasons, not just because of the global cost, but because of cost to individuals, especially if they have health plan products that have a high deductible. That we, as you note, have some challenges about the Secretary's ability to negotiate the price of drugs, and in the President's budget have asked for some additional opportunities for the Secretary, in this case for her to be able to do that. So there's some congressional interaction that we've asked for. In the meantime, we have done undertaken some strategies to lift up a dialogue about it, to make clear that we're paying attention and interested, and posting the cost of drugs online. We've developed a website through cms.gov that posts the cost of drugs. We've been working strategically in areas like Medicaid on hepatitis C drugs and providing guidance and clarity to state Medicaid directors about their opportunities for cost control. Those are some of the examples. I think where you're going is a place that we've been actively engaged globally, is understanding what are the strategies that have been successful in other countries. And as you can imagine, it's quite variable, but we're working to find a way if that's going to be sort of a shared solution. So it's a high priority. We're tackling it through a variety of avenues, but we know that we have a lot of work to do in that area for individuals and communities.
Let's go to our colleague from Detroit.
Abdul Sayed, Detroit Health Department. So, we're here and we're having a fantastic conversation about public health, but it's hard not to ignore that in Cleveland there's another conference happening and things are happening there too. And it's hard not to feel like we're in a moment. And so from where you sit, it would be really helpful to understand, A, what you're really worried about, fundamentally worried about when you look 5-10 years on in the future, and then hopefully on a brighter note, what you're excited about. Future.
Well, I have some comments tomorrow, so I'm going to refrain and defer to the panel today, because you'll hear from me tomorrow morning. So anyone wants to take this?
I'll jump in and then pass it on to my colleagues. When I say what I'm concerned about, it is disparities. I think it's the disparities that are based upon, in particular, income and race and discrimination that I think have proved to be very challenging for us to make progress in. I'm very optimistic on the positive side about the opportunity that has been created by the ACA and by the greater attention to social determinants of health. I looked very happily at the closing of the gap for the first time that in history, I think, between the percentage of uninsured that were black and that were white, and a slight closing, but not much, with the Latino population compared to the white population. So I think that's promising that we've expanded the access to health care to address some of the disparities. But that said, I think we need to, unless we redouble our efforts and really make it clear that we've got to put resources, attention, specialized efforts into the programs that address disparities, I don't think we're going to be making the kind of progress we need.
And I'll just add to what John said, in terms of what I'm concerned about. If you read the definition of health equity for the department, it says it's the attainment of the best health possible, but then there's a subtext that starts with, it requires that we value all people equally, and then there's more. I worry that we don't value all people equally. And I worry that we're seeing that in some kind of very explicit ways. But where I am hopeful in terms of the next 5 years in the next 10 years is that communities will come to realize that we all do better if we're pursuing equity and health equity, and that there's more that we have in common than what we're competing for, if you will. And so I just see in the future being communities actually coming together, laying aside differences, and working toward some common health outcomes.
Abdul, first of all, I agree completely with what you all said, and I'm going to add a layer, which is the thing I'm most urgently worried about is that as a country, we're not going to take this opportunity to recognize that health and health equity is going to take more than great health care, and that we don't change not only the point of view and narrative, but the way we invest in this country, away from reinvesting still in health care, pulling people out of the river, and start to move significantly upstream. The timing is right, because though we're not finished, we've made such great progress on the healthcare front, but we have to begin to think about the reinvestment. The opportunity, the hope that I have is I hear this from all corners. I hear from the business sector, from faith leaders, from civic society, from for-profit hospital associations, an understanding that there's more to health than healthcare, that your zip code is more predictive of your outcomes than your genetic code, all these phrases that start to capture the imagination. And I think but we have to seize the opportunity because of what we're seeing in the data around mortality, which is the other opportunity that I think and this speaks directly to people like you who are so good with it. Data, when it becomes information, when it's presented in ways that are digestible, is democratizing in many, many ways, but also in the way of health. And if we use the information that we have properly, we're going to be able to better understand disparities, better understand how we can make a difference, and if we're making a difference as we go forward. So I think it's incumbent on us to push that conversation, to get the right people understanding that we have to invest in health, not just healthcare, and that we're going to have to use information in a more open and transparent way to know how we're making progress.
Thank you. Great question. To our colleague from Cook County.
Hospital. I'm sorry, Terry Mason from Cook County Health Department. The question that I have is, since there is a natural or inherent misalignment of the value propositions for the so-called healthcare industry and really health, I'm wondering how we begin to deal with that. Secondly, the next issue I have is, when do we start focusing on turning the spigot off for the cause of disease? To follow your point, Dr. DeSalvo, when do we start looking at policies at the USDA level? When do we start looking critically at the flooding of our schools with the surplus of the commodity crops and the commodity programs that are actually helping to poison our children more than they are giving them the kind of nutrition? And we're currently looking in Chicago, in Cook County particularly, at communities that have been disenfranchised of good food for so long that the appetites are gone. So you could put the good stores in those communities and people won't buy the food because they've lost the appetite or even know what to do with them. So the question is, how do we begin to really impact the subsidy programs for what is cheaply grown, so that we can make, I get mad as hell because I have to pay more for good food. So why aren't we in this country, knowing that at the core of our so-called cardiovascular disease, a third of our cancers, why are we not absolutely insisting on better subsidies to make good food cheap and widely available?
Thank you so much. In the interest of time, we're going to do a rapid fire, hold that thought panel, okay, food security subsidies. We're going to go here and there, and then we're just going to do a rapid fire and trying to answer some of these questions with some quick nuggets. So you, sir, and then we'll go here.
I'm Douglas, Tri-County Health Department, Colorado. My question is, Hal, it's great to hear 3 buckets in Public Health 3.0, and I'm interested in how the 3s are going to be used. I'm sort of getting my head around the buckets and how I might use those. Karen, I'm wondering how you see that Metaphor 3.0 maybe being operationalized in any HHS sort of thinking, strategies, et cetera?
Thank you. We'll go here for the last question.
There it goes. Hi, my name's Doug Judy. I'm a public health professor at UC Berkeley and director of the Build Healthy Places Network. And my work is really around trying to bring the community development sector and the community development finance. Those are the folks that build the grocery stores in the food deserts and the affordable housing, the community centers. I work with the Federal Reserve System. And they're increasingly seeing their work as being health promoting, that they really are public health practitioners. So I'm curious from your perspectives, they're looking for measures of impact, but on a frame that is consistent with their needs for their investors and that their infrastructure, the links are not direct between what they're doing, which is critical, I believe, in improving the nature of communities, but the healthcare outcomes and the cost savings are disconnected. Do you have any suggestions about how we can make that connection tighter so we can encourage more money going into that arena?
Thank you all. So let's take on the food subsidies issues first. I'll have one of our panelists address that. Who's burning to hit that one?
Look, let me just take it up a notch. I absolutely hear what you say, and I think that this gets into a broader issue that I raised a moment ago and that you also raised, which is that there's a business model in this country that supports about 1/6 of our economy, and it's healthcare. I come from the House of Medicine, so I get it. But on the other hand, it's still a disease model. We're going to push that. The reason I raised the issue, for example, of moving to value-based payment is because we do recognize that one of the most important levers that we have through Medicare and other programs is to get the healthcare system to recognize that there's more to health, and they've got to work with community partners, but that's but one of many things that will need to occur. The issue around equitable access to the kind of a healthy community that we all want is going to take this broader approach, this 3.0 approach, and this is something we're trying to quantify, not only because we think communities that are doing it well are showing us that they're changing the numbers, they're changing access, they're working across sectors in different ways that we need to try to describe so it can be replicated, but also because we at HHS and the federal government need to lead by example, which is what I hear you saying, and I couldn't agree more. I think we have much more that we need to do, much more thoughtfully across sectors, and we've been learning a lot about that, quite frankly, in Flint, about how we could do a better job working with our partners across the federal government.
Thank you. I'm going to go to John to handle the one on the community development sector and how we can leverage those assets and that interest.
Sure. So I'd say that's, thank you for asking that question. I think that is an example of where public health has to work in partnership, that we can't do it by ourselves. It just wouldn't be possible, and we know that very well, and that what we need to do is work with other sectors that have a major impact on the lives of people through housing, transportation, education, et cetera. And you raise a really important opportunity. So I think that is, I think, part of this new vision of where public health needs to go, part of the notion of chief health strategists for the future. What I think is, it's not easy. That's, as someone who was a local health officer, I could sometimes see the things I needed to do, but I couldn't figure out how I was supposed to do them when my funding was categorical and I was laying people off and I was grappling with all the immediate headaches that would come your way as a local health officer. So I think what we need to do is to be really practical about how can we, with the resources we have, with the challenges we have, how can we give ourselves, learn those tools that are going to allow us to convene people, use data, use the evidence base we can draw upon, understand what those opportunities are, and really begin to work in serious, authentic partnership. But not easy. But I think that's the challenge that we face collectively.
Thank you. So we had another gentleman ask about operationalizing the 3 buckets and then 3.0 in turn. So if you guys can give a brief nugget on that.
Well, I would say briefly, what I think we need to take advantage of the opportunities that exist now in order to move make progress. And I think some concrete and specific opportunities exist because right now, in every single state and in most communities, there are discussions about the changing health system that deal with access and they deal with payment. Public health isn't always at the table, and we have to fight to get to the table. But when we get there, we have to have something to say that is credible, that's evidence-based, that increases the likelihood people will say, it's a good thing public health showed up. And so I think that the three-bucket approach and this notion of tools and being ready is part of thinking about seizing the moment now when these opportunities exist.
You mentioned the transition in the administration and sort of the thinking of how we seize the moment. And I'll use healthcare as the example. I'm a primary care physician and spent a lot of my time working on patient-centered medical home. And I think there was a turning point for primary care when we came together and defined what good primary care was and worked on an accreditation process and were willing to be more open about reporting on data and quality as an example. That gave us a shared language to take to Medicare and private payers and to Congress to see that there was a way to fund not just the services, the fee-for-service model, but coordination and some of the interstitial stuff that we do. And also started to help define what a gap might look like in funding. And it's really pushed the agenda on payment transformation and practice transformation for primary care in this country, and we're making progress. And I would say the same sort of effort I believe needs to happen in parallel for public health, and that's the 3.0 notion for me, is that there's a place where we have to come together and agree that this is what good public health is, this is how you know it when you see it, this is how we're going to come to the table, not with a program, yes, with a program around cardiovascular disease or around equity, but also come saying it requires core infrastructure to do this work every day. We're underfunded by X amount, and we require this additional FTE to be able to meet the needs of the population. In the absence of a gap analysis like that, in the absence of undergoing a payment transformation in the way that healthcare did, I don't think public health is going to be able to always be at the table and lead at the table where appropriate. But I charge out to you all as NACCHO, but also as a group of public health leaders. Healthcare did much of this themselves. They looked internally and said, we're going to Congress or Medicare and asking for different things all the time. And when there was increasingly a shared definition and an ask, boy, the dial started to move pretty fast. And so I think it's incumbent upon all of us as public health professionals to get really tight on those numbers, to do work like they're doing in Texas and Kentucky and Washington, and start to really understand if we were to be asked, what would we say was the dollar gap, the FTE gap, the data and infrastructure gap that we had, so that we would be ready to run through that door when it opens.
So,
I could just,
yes, please.
Yeah, I just want to add one thing that we haven't really talked about, which is the community benefit program through local hospitals and their requirement to do needs assessments and to put resources back into the community. And I would be very interested to know, to hear from all of you examples of where that partnership has been a fruitful one. Because I think what we do is we learn from each other and we build upon those successes as we put them in different communities. So I think that's an important one.
So to John, Leandris, and Karen, I want to thank you guys for your compelling perspectives, but more than that, your candor, because I think you really facilitated an honest dialogue. So please join me in thanking our panelists.